Good evening everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaj. Download Incus app. You have 2000 HD videos, 60 full-scale grand tests, 70,000 MCQ question bank, 3,500 quiz tournaments, 70,000 MCQs as revision flashcards, and 1 lakh PowerPoint slides of notes. Don't wait anymore. Today only download the Incus app and become the topper in the NEET PG exam. Let me give you a quick revision for the NEET PG on the most common essential things which are very high yielding for the NEET PG in the form of short videos, 10-minute, 15-minute videos. Mittendorf's dot. So what is Mittendorf's dot? Mittendorf's dot is the remnant of the anterior end of the hyaloid artery and it remains attached to the posterior pole of the lens. So when we talk lens, think of Mittendorf's dot. It is a remnant of the hyaloid artery's anterior end, which is typically seen in the posterior pole of the lens. Bergmeister papilla. So it is a remnant of the posterior end of the hyaloid artery, whereas Mittendorf is anterior end of the hyaloid artery. And typically it remains attached to the optic disc associated with some glial tissue. That is Bergmeister's papilla. Then coloboma. What is coloboma? Coloboma is the failure of the embryonic fissure that gives rise to ocular coloboma. Then persistent hyperplastic primary vitreous. So a lot of fetal vasculature, it fails to regress, and that is called persistent hyperplastic vitreous. So what you are able to see is a congenital cataract with a persistent hyperplastic primary vitreous is what you are able to see. This is how grossly a persistent hyperplastic vitreous looks like. Now this is what we are talking in the lens. Mittendorf. A Mittendorf's dot is what you are able to see. Now, vernal keratoconjunctivitis, one of the very high yielding facts. At least every topic in ophthalmology you should know. 10 points for the tomorrow's NEET PG. Vernal keratoconjunctivitis. It is allergic keratoconjunctivitis. Boys में होता है between 5 to 15 years of age. What type of hypersensitivity? Type 1. All allergies are type 1. IgE mediated mast cells are involved. It is also called spring cataract, and itching will be there. Ropey discharge. You need to remember when it comes to this allergic vernal keratoconjunctivitis. Then if you look at the conjunctiva, all these flat-topped papillae, they are all seen in the upper tarsal conjunctiva. See, you have a upper and lower tarsus, no? Two eyelids are there. Upper tarsal conjunctiva you see. And this is called the cobblestone, just like this cobblestones are there, no? Like that you can see cobblestone appearance. Then there is another variety called limbal variety, that is where corneoscleral junction is there. There is a hypertrophy of the superior limbal conjunctiva, and that gives rise to white nodules close to the upper limbus. They are called Horner's Trantos spots, is what you need to remember. So typically at the upper limbus means corneoscleral junction. So upper part of the limbus में Horner Trantos dots, you should remember. Then in the cornea, what are the features? There will be superficial punctate keratitis. Shield ulcer is another important feature. And there is a curved white line. This is a curved white line. So there is a curved white line close to the upper limbus, which is called pseudogerontoxon, is what you need to remember. Then one favorite MCQ is, what is an important association with vernal keratoconjunctivitis? Keratoconus is associated. So how do you treat after antihistamines, steroids and cyclosporine? And for the prophylaxis, for the allergy, you give sodium chromoglycate, ketotifen, olaptadine, epinastin, all these anti-allergic agents prophylactically. That is all very important things you need to remember. Now, what is the WHO classification of trachoma? Is the favorite question of the examiner. You should remember Fisto. F is follicles. Kitne follicles? More than 5 follicles, larger than 0.5 diameter, 0.5 mm diameter. Kaha? Upper tarsal conjunctiva. Then there is inflammation, intense inflammation with thickening of the conjunctiva, obscuring more than 50% of the deep tarsal vessels. Then scarring. There is an evidence of cicatrization with white lines, bands of fibrosis. Then tracheitic lash. You can see here, tracheitic lash, trichiasis. And corneal obesity, which is obscuring the visual axis, causing a visual acuity decrease to less than 6/18. Fisto is what you need to remember. Follicles, inflammation, scarring, trichiasis and opacity. Now, the next favorite tequila shot-like question. So, tomorrow you may become a top cardiologist, neurologist, psychiatrist. You may not need all these things, but for entrance exam, you need to remember sportively. Osteogenesis imperfecta, period, Seldan, Marfan, staphyloma, healed scleritis, you see blue sclera is what you should remember. Now what is staphyloma? भैया staphyloma होता है ectasia. Ectasia means outpouching, right? So ectasia of the outer coat of the eyeball, where there is an incarceration of the uveal tissue. What is uvea? Iris. ICCU is uvea. Iris. C, ciliary body. C, choroid. That constitutes uveal gland. So this uveal tissue is incarcerated into this ectatic part of the eyeball is staphyloma. It can be anterior whenever there is any perforated corneal ulcer. It can be intercalary within 3 mm of limbus whenever there is a peripheral ulcerative keratitis. It can be ciliary, it is posterior to 3 mm from the limbus in the case of the healed scleritis, and it can be equatorial if there is high myopia or healed scleritis. It can be posterior behind the equator if the eye globe is there, behind the equator if the uveal tissue is bulging. That is seen in pathological myopia, posterior staphyloma. This is what examiner is going to ask you in the tomorrow's exam. So this is the classical example. What are you seeing here, doctor? Ciliary and intercalary staphyloma is what you are able to see. Now one of the favorite questions होता है entrance exam में, what are the layers of cornea? Be very sure. One of the many times asked this question, favorite MCQ. Epithelium is made up of what? Stratified, squamous, non-keratinized epithelium. Then you are having Bowman's layer, stroma, thickest layer, Decimet's membrane, toughest layer, endothelium, most metabolically active layer, which is basically made up of single layer of hexagonal cells, is what you should remember. Now few things which we use to do the assessment of cornea. Assessment of cornea is the favorite question of the examiner, doctor. What is patchimetry? Here you are doing patchimetry. You are measuring the corneal thickness. Keratometry, corneal curvature. Corneal topography, the curvature, shape and thickness. Specular microscopy, to know the corneal endothelium. Because there are some corneal dystrophies where endothelial reserve of the corneum is decreased. Right? So, specular microscopy. Confocal microscopy, to evaluate all the layers of cornea. Then what are the important stains we use? Fluorescent stain to know the epithelial defects. Rose Bengal stain, it stains the degenerated epithelial cells, but it causes a lot of stinging. That is the reason it is rarely used nowadays. Now, one of the favorite MCQ of the examiner in the corneal ulcer is hypopion corneal ulcer with a very rapid progression and also chances of perforation. कहाँ होता है? Pseudomonas can lead to hypopion ulcer with perforation. Ulcer serpens, where do you see? Pneumococcus. And what is the most common causative organism leading to fungal ulcer of the eye? In India, corneal ulcer, it is the aspergillus. You can see these feathery margins are there, no doctor? Feathery, feather law. Please bring a feather. Feather. So feathery margins are very typical of fungal ulcer. And what is the drug of choice for fungal corneal ulcer? Netamycin. And what is the drug of choice for the fungal corneal ulcer which is non-filamentous? Amphotericin B. And will you give steroids? No. Absolutely contraindicated in corneal ulcer. Both the bacterial fungal ulcer. Dono mein steroids are contraindicated. And whenever corneal ulcer is there, why do you give atropine? Because there is a lot of pain because of the spasm, ciliary spasm, which is all because of the parasympathomimetic action. And to break that, you have to give a parasympatholytic, and that is your atropine, is what you need to remember. So, like that, खेलते साथियों के साथ मिलके prepare only high yielding content. What is going to be asked by the examiner? Your total preparation time for the ophthalmology, doctor, take it as my word, should never be more than 20 hours. 20 घंटे से ज्यादा अगर नीट पीजी के लिए आप ऑप्थेल्मोलॉजी पढ़ रहे तो पागल हो जाएंगे. ये 20 घंटे में ही you have to master everything that examiner wants. So please don't forget, पूरा दुनिया में nobody will offer the coaching program so cheap. Only Incus in rupees 999, 3-year subscription, 2000 HD videos, 60 full scale grant tests, 70,000 MCQ question bank, 3,500 quiz tournaments, 70,000 MCQs as revision flashcards, 1 lakh PowerPoint slides of notes. Don't wait even a single minute. Just open your Google Play Store. Please write a 5-star comment and a 5-star rating on the Google Play Store. We will be really grateful to you. And also tell another 100 of your classmates good about Incus, and that gives us a chance to become more helpful and useful for many more COVID variants preparing for the NEET PG. Jai Hind.